to discuss? You might be thinking, well, I've been watching a few times. It seems like it's neurology. It's kind of hard. I'm not sure. That's a great reason to participate. You'll learn some neurology in the process. You'll have fun. You've seen how much fun we have. Or you might be thinking, English isn't my first language. I'm not 100% sure. Don't worry. We have Spanish speakers, Portuguese speakers, French speakers, everything speakers. So we can help you out there. All right, we have a discussant, William Remley. Fantastic. Anyone like to discuss with William? Ideally, someone identifying as a woman. And did anyone have a case? Let me just scroll. Promise, fantastic. Yes, you've discussed before, which was excellent. But Promise is offering, if anyone else hasn't discussed before and would like to discuss. Going once, going twice. Promise, you're hired. Okay, Promise and William, if you don't mind briefly introducing yourselves. And then I think if no one else has a case, Doug has 1 million cases because he's in his last year of neurology residency and he will select from that million for us today. So if the three of you don't mind introducing yourselves, and then we'll get started.
Hello, my name is William. I'm a fourth-year medical student from LECOM, and I'm applying into neurology residencies this week.
Fantastic, future neurologist. Wonderful to have you. And do you go by?
I typically go by Bill.
Yeah. Bill, got it. Fantastic. And then Promise and Doug.
Hi, I'm a second-year medical student in the US, and I have a huge fear of neurology, which is why I'm discussing, and we're in Neurological right now. We just started, and I'm already really scared.
Fantastic. Facing your fear, facing your neurophobia. What better way to do it than Neuro VMR? So that's fantastic. Thank you, Promise and Bill. And then Doug, a quick introduction, then we'll get on with it.
Hey, everybody. I'm Doug Pett. I'm neurology resident here at UCSF in San Francisco. Proud member of the CPS team on the consult question, and love working with Aaron and all the folks on Neuro VMR. Glad to be back.
Fantastic. And those of you who are here frequently know that the last Tuesday of every month, I have a fixed 10 a.m. meeting in my day job that I cannot miss. So that will require us to try to make sure we actually finish on time, which can be a little bit rare in Neuro VMR because we just end up having so much fun, and which means I may have to duck out before the teaching points. But with that said, let's see what we can make of the next 53 minutes. So Doug, if you'd like to give us just the chief concern, chief complaint, and we'll get started.
Sure. This is a patient presenting with gait disturbance.
Gait disturbance. Okay. Bill, what comes to mind when you hear gait disturbance? What are some of the things you'll be thinking about as we go through this case?
So right off the bat with gait disturbance, I'm curious, like what type of disturbance? Like, is this like a coordination issue, or is this more of a weakness issue? We don't know anything about this person, like the age or how long it's been going on. But given the more specific symptoms or like what it feels like to that person, I mean, a gait disturbance could even be like they just feel lightheaded as they walk around or if they get up too quickly. So there's like really a lot of different things. Could be, like coordination or just a decreased proprioception, like a lot of different things.
Fantastic. Yeah, great thoughts there, Bill. So yeah, first of all, what does a patient mean by gait disturbance? Unless it's a medical person presenting, right, and they say, I have a gait disturbance, right, probably we'll hear in the history in the patient's words what was actually meant here, whether it's a true difficulty with the mechanics of walking, or as Bill astutely said, is this something more to do with dizziness, vertigo, lightheadedness that is making walking difficult in that scenario? And then if it is truly the walking, as you said, Bill, we do the whole neurologic exam, right? Mental status, cranial nerves, motor, sensory reflexes, coordination, and gait is at the end, because I always say gait is sort of like the symphony. You need all the instruments, right? So Is there a problem with weakness of the legs? That could cause a gait disturbance, right? Is there a problem with proprioception, as Bill said? If the patient can't feel where their feet are in space, then they would have trouble walking. Is it a problem with coordination? So you've tested your strength, it's fine. You've tested your sensation, it's fine. But you see that in spite of that, the coordination is difficult for this patient. And then at a higher level, we can have gait disorders that are more cerebral, so to speak, or due to problems in the hemispheres where strength is intact, sensation is intact, coordination is intact. And as Bill said, the first thing is we want to see what actually it looks like when the patient walks, because if all of those functions are okay, there might be a problem with what I call the gait app in the brain, right? So you have to have certain data, right, to be there to run the gait app and to be able to walk, right? Something we all learn to do. And so you need structures like the basal ganglia that coordinate some of the initiation and patterning of movement. And you need some of the frontal centers that communicate with motor areas to coordinate, and broadly speaking, our gait, right? Which is why in normal pressure hydrocephalus, the dilation of the lateral ventricle stretches some of the frontal fibers that make it difficult to sort of do the higher level aspects of gait. And one of my mentors, Alan Roper, showed me this incredible clinical sign. I'm not sure if it has a name, but you'll see this written about that patients with normal pressure hydrocephalus, you can see they have a lot of difficulty with their gait, despite being strong, having good sensation, good coordination. But if you ask them to just sit in a chair and bicycle their legs, also rhythmic and patterned, they do it perfectly. Sometimes they can even walk backward better than forward because they're not activating that gait app that sort of gets you up and going. They're doing something different and then calling on the mechanics of patterned, coordinated, rhythmic leg movements through another way. So yeah, we could be anywhere here, right? And even if we say this is weakness, we have the whole motor system to worry about. If we say this is proprioception, we have the nerves and up through the spinal cord, right, the dorsal column. So as Bill said, this could really be anything because gait is sort of a symphony of all of these individual actions. All right, so that was great. Bill, Doug, why don't you go ahead and give us the HPI, and then promise we'll have you see what you think of that.
Okay, let's see. So this is a 62-year-old gentleman, 62-year-old veteran who I was seeing in my VA outpatient clinic, who was a prior longshoreman in the Marines, and about 5 or 6 years ago started developing what he called a limp and worsening of what he called his neuropathy pains, which over the course of about a year made him need to quit his job, unfortunately. He described the pains. He had, I'll skip a little bit ahead. He said he had a history of bilateral frostbite injuries on both of his feet when he was a kid. And he referred a lot of these symptoms to that frostbite injury. He said, I had pains in my feet, but he also said I had shooting pains and cramping spasms in my calves, in the outsides of my thighs, sometimes shooting into my groin. And over the course of about 5 to 6 years, what he called his limp and his just difficulty walking in general got worse. And he started to have falls about 2 years ago. He additionally says that he has had, starting about 5 years ago, he started having urinary urgency with a few episodes of urinary incontinence, and there was 1 year where he had occasional fecal incontinence, but that has since resolved. Other things that he mentioned in kind of his review of system is that he has had started having erectile dysfunction around that time, and that had never been a problem prior to that. He never reported any concerns in his arms or in kind of his upper body. And he comes to me on the day that I saw him because he was having ongoing pain and worsening of his cramping and spasms. And his new primary care doctor was concerned that his falls had not been really figured out.
Okay.
Should I give some medical history? Do you want to stop there?
Up to you. Do you think it's worth just getting it on the table now, or if you prefer to hold it then?
I think it would be fine, actually.
Sure. Okay.
Let me give you, so his past medical history is notable for the frostbite that I mentioned. He's also been diagnosed with peripheral neuropathy in the past. He has an extensive substance use disorder history, including prior alcohol, methamphetamine, cocaine, and IV heroin use. Last use was about 7 years ago, he says, with regard to the IV drugs, but more recent use of inhalational meth. He has a depression, anxiety with some, as well as chronic hepatitis C with positive cryoglobulins that has never been treated.
All right. Oh, sorry. Go ahead. Yep.
And then just to round that out, his medications, he also has hypertension, takes a couple different hypertensive medications. He's on tamsulosin for urinary issues. He's also been diagnosed with BPH. He takes thiamine and gabapentin for his pain, folate, B12, and a proton pump inhibitor.
Got it. Okay. Lots of information there. Promise, what's coming to mind? You can take one piece of this or some pieces together, whatever you'd like to do as far as discussing some of this extensive information that Doug just gave us.
Yeah, I agree. This is a lot of information. I feel like I'm still trying to organize and kind of see where I should focus on. But I think something stood out to me was definitely the time course. This doesn't, it has been happening. And then I just see a lot of different symptoms coming into play as well. So I feel like I don't know too much about the pathophysio yet, but I feel that if it was like a nerve damage, it's more it seems like it's more localized to the lower the lower part of the body. And I would be worried about like some kind of illness that leads to like kind of like all the lower body nerve damage. And then I thought the diabetic peripheral neuropathy was interesting because that could explain the gait issue, but it seems like there are also other issues going on. So I don't really know how to clue into that yet. And then I feel that with his substance use and also his alcohol, all of that could affect his nervous system as well. And I feel that because he has it sounded like he kept referring to his frostbite as a child. I wonder if it could be like a infection he had as a child, and then it's kind of like reactivating or something. But that's kind of all I have right now.
Yeah, great thoughts. You're picking up on some of the challenges in putting this case together, as you said, which is trying to organize all this information, right? And as many of you have heard me say before, sometimes you have all this information we like, and especially morning report, right, to have this perfect Venn diagram of 12 things, and the diagnosis is the one thing in the middle. And yet, as we know in real life, patients are complicated. They have lots of past medical history. They're on lots of medicines. They have lots of symptoms. And sometimes those separate circles on the Venn diagram are all true, and there's sort of nothing that falls at the center. So I think you're asking the right questions, Promise, which is what's sort of new and what's old here, right? So we have a history of peripheral neuropathy. We have a history of frostbite. I think you said diabetic peripheral neuropathy, but as far as I could tell, we didn't hear that we know the cause of this as being diabetic, though you're right to hear peripheral neuropathy and wonder about diabetes, because that's the most common cause in the world of peripheral neuropathy. But is this prior condition in some way becoming exacerbated? Is this prior condition evolving in its normal pattern? This is happening over years, or is there some new superimposed process here? And then what, if any, relationship is there to the history of substance use? So those are, I think, the right questions to ask, and fantastic questions to ask. And we'll have to figure out whether we can answer them. Since there's so much information here, Bill, do you want to add anything as far as what you're thinking? No obligation to. We can have you hear the exam first, but any thoughts that are coming to your mind on all this information we've gotten here in the history?
Sure, that was rich. There was a lot in there. That was good. So there's a couple different patterns of symptoms I was seeing. So those like frostbite injuries, like Promise said, like when we think like maybe like some persistent nerve damage since like from childhood. And then so there's different like shooting pains in the thighs and the groin. So it kind of sounds like maybe there's like a stenosis going on at the level of like in the spine, maybe like a shopping cart sign or something like that. But it's still, you know, not too sure about that. But then also he mentions like it sounded like almost like claudications, like maybe some like peripheral arterial disease. It's kind of like those kinds of symptoms going on. And then the falls, you're really not too sure about that. But then 5 years ago, he was only 57. So that's when he started having the urinary urgency and incontinence, which is very, very young. So are these like autonomic symptoms that could be associated with some systemic disease? Or is he just a vasculopath and then is having like severe like arterial disease? With different resulting symptoms. Also, like Promise said, with his long history of substance use and abuse, I know he said he takes folate and I think B12, but it would definitely be on the differential, like different vitamin deficiencies, just to make sure that he's getting his nutrition. And then with the hepatitis C and the untreated cryoglobulins, it's definitely like makes me think about a peripheral neuropathy associated with cryoglobulinemia. So it's a lot of different things going on at the same time that I'm curious about.
Yeah, great discussion, Bill. So yeah, I think if we take things sort of in the order the patient describes them, right, the prominent symptom we see, and if we did a search here, right, of our little Google window, right, the word pain just keeps coming up over and over again. And so this patient's chief concern, literally and figuratively, right, is pain. So I think it sounds like Doug and his colleagues tried to explore that. We heard that it's shooting, it's cramping, there's spasms, and just taking that by itself, we could think of things like a polyradiculopathy, right, where there's root compression in the lumbosacral spine causing sharp shooting pains into the extremities. Neuropathy itself, peripheral neuropathy, can be painful if the small unmyelinated fibers that are sensitive to pain are affected, and they can, I'm not sure any of us know the mechanism, but presumably they are giving the false alarm that pain is there when it is not, and that can be very painful and have that sort of similar kind of electrical sensation. Although we would have to wonder if this patient had a neuropathy, peripheral neuropathy, severe enough and progressive enough over 5 years, why has it not affected the upper extremities yet, right? So when I hear about something in the bilateral lower extremities, and Doug did say at one point that there's no problems in the arms at all or the upper body, though we'll see on exam, right, if the reflexes are absent or there's other findings that suggest this process does go up more superiorly. If I hear it's just both legs, this has come up before in VMR, right? Very rarely you could get bilateral leg weakness from a well-placed parasagittal lesion affecting the bilateral leg areas of the homunculus. That's super rare, bilateral ACA strokes or a parasagittal meningioma. But barring that sort of gourmet neurology diagnosis, right? If we hear about both legs, nothing above the legs, we're thinking about the spine and below, right? So spinal cord, cauda equina / nerve roots, right? Or peripheral nerves. And in this case, we can take off probably things like neuromuscular junction disorders or muscle disorders, right? Or motor neuron disease because of all this pain and all these sensory symptoms, right? So this is, we're not sure yet if there is weakness or if all of this difficulty with walking is due to pain. We're going to find that out in the exam. So what do we have here? We have 5 years of progressive painful symptoms limited to the lower extremities. And then superimposed on that, we have disturbances in sphincter function, right? So it's very rare with neuropathy to get sphincter dysfunction just because the nerves between the spinal cord and the sphincters are so short, right? So even the most severe neuropathies, even patients you've seen with the most severe cases of Guillain-Barré, where it seems every nerve is affected, generally there is not significant sphincter dysfunction. So that pushes me more towards the spinal cord or the cauda equina. that's probably all I can do with that. So then what do we do with this past medical history, right? Well, as Bill said, if you hear hepatitis C and neurology, right, your Venn diagram goes to a neuropathy. And do you know, Bill, the particular pattern of neuropathy that tends to be associated with hepatitis C? No, it's mononeuropathy multiplex, which is very uncommon, right? So when we think about peripheral neuropathies, we think of mononeuropathies, right? Like carpal tunnel syndrome, which is the median neuropathy of the wrist, ulnar neuropathy of the elbow, perineal neuropathy of the fibular head, et cetera, et cetera, et cetera. Those are the common ones. You can think of polyneuropathy, which is what we generally mean when we say peripheral neuropathy. These are the symmetric neuropathies of things like diabetes, B12 deficiency, chemotherapy, et cetera. And then in the middle, the one that step one loves, but is actually very uncommon in real life, is mononeuropathy multiplex, which means multiple individual nerves affected. So peripheral polyneuropathy, all the nerves are getting affected at once. Mononeuropathy multiplex is an interesting pattern because you sort of get one nerve after the other. So a patient gets a wrist drop on one side, and then they get a foot drop on the other side. You might say, why is he saying mononeuropathy multiplex? Why isn't he saying mononeuritis multiplex? That's what I learned. And that's because the pattern isn't always caused by an itis, caused by an inflammatory etiology, but the most common, though still very rare, etiologies are indeed inflammatory. So hepatitis C with cryoglobulinemia can cause a mononeuritis multiplex. Polyarteritis nodosa associated with hepatitis B, though not always, can cause a mononeuritis multiplex. But there are conditions like hereditary neuropathy with predisposition to pressure palsies, HNPP, due to a mutation in the PMP22 gene can cause a non-inflammatory, so a mononeuropathy multiplex. Leprosy can cause that's probably an itis, mononeuritis multiplex. Even diabetes, which can do anything that we usually see length-dependent peripheral neuropathy, can cause small fiber neuropathy, can cause mononeuropathy multiplex. HIV, which can do anything, most commonly causes a peripheral polyneuropathy, can cause a mononeuropathy multiplex. But when you see this pattern, it's a pretty short list on the differential, and you would be looking for hepatitis C if it wasn't already there. So it's hard not to think about that condition in a patient with untreated hepatitis C. Now you might say, well, this patient didn't have, though, what you said, a painful wrist drop on one side and then a painful foot drop, painful when it's itis. But there is another pattern of mononeuropathy multiplex, just to muddy the waters even more, that is not this sort of classic, very asymmetric pattern where it's much more confluent. And presumably it is multiple individual nerves, just so many in such a small area that it's a more confluent pattern. And I have seen that once or twice. So I think that's sort of on the differential, though my understanding, which is not based on many cases, is this is super, is that you wouldn't see bowel bladder dysfunction with that. So that sort of pushes me back into the cauda equina realm, and then I wouldn't know too much what to do with all of that medical history and a cauda equina syndrome. As far as the substances, alcohol most commonly causes a neuropathy, and particularly a symmetric painful neuropathy that can cause anything. And then long-term alcohol use can also cause cerebellar dysfunction. So this patient may have a multifactorial gait disorder. He's a little bit young, but most older patients that come for gait difficulties, 75 or older, usually they have a little neuropathy and they have a little bit of spinal stenosis and they have a little bit of hip pain and arthritis, and it's kind of a little bit of Parkinsonism. It's a little bit of everything, and it's hard to know what the main thing is. Probably the only other thing that popped into mind for me is when you hear about all these shooting pains and gait disorder, a little autonomic, and just recency bias, because Doug has stumped me in the past with a case of syphilis. Now, every time I hear a case from Doug, I have to wonder if it could be syphilis. And tabes dorsalis, which is extremely rare. I've never seen a case, and is much rarer in present times than it was when it was described. I believe, someone correct me if I'm wrong, I think, Maria, you and I both read this article about the Romberg sign, right? That it was actually described in the context of tabes. Correct me if or tell me in the chat if I'm mixing things up, or that's my appropriate recollection of that's how Romberg came up with his sign. But tabes dorsalis, although we think of it as causing proprioceptive difficulties, the classic description is there's a lot of shooting, lancinating pains throughout the abdomen and throughout the legs. So that's another thing to throw on the differential here. So as we move into the exam, I think we're going to be very curious to see what evidence of neurologic dysfunction we can find. Is there any weakness, or is this truly a gait disorder due to sensation? Back to Bill's initial description, or initial sort of framework for this case, right? Is there any coordination difficulty? Is there any proprioceptive difficulty. Peripheral neuropathy is on the patient's list. Do they have actual evidence of that, or something else has been called peripheral neuropathy due to the symptoms without objective findings on the exam? So as we move into the exam, Promise and Bill, what are you most interested in looking for here that's going to help us sort out the localization here? If you could do 1, 2, obviously we'll do a whole exam, we always do, but what are the things that are, as you get ready to start examining the patient, that you're kind of most eager to see to help us make some progress in this case?
It's on first exam. You want to find out about the motor strength, definitely. And then heel shin to test like the coordination. And then, because it's like you said with like normal pressure hydrocephalus, you like, it could be like the coordination may be fine. Maybe a finger, nose, finger, I don't know. But yeah, if the motor exam is okay, then it leads to other things.
Yeah, exactly. So we always get the history first, right? But we would have seen this patient walk into the clinic, and we would have seen, is there a steppage gait showing us there's a foot drop? Is there a sort of antalgic limping gait from pain? Is there the magnetic gait of hydrocephalus, the wide-based, very unsteady gait of ataxia, which might be sensory or cerebellar? So we would have had some clues. Is there a Parkinsonian gait here? Doesn't sound like that's on the table, though there may be some elements here that will be hypothesis confirming and others that will be hypothesis confusing, right, as we examine this patient. So yeah, we'll want to know, is the strength intact? That takes a lot of things off the table, right? The motor system is cleared, right? Is the coordination intact? That would take the cerebellum kind of off the table. And to some extent, if there is really no ataxia at all, it's hard to invoke a proprioceptive etiology as well, because you could get a sensory ataxia, but we can discover that objectively with our tuning fork and our proprioception. Good. And then I think the reflexes will be very informative here, right? If this patient has a progressive spinal cord pathology, right, then we should see upper motor neuron signs to go with that. And if this patient has progressive neuropathy or radiculopathy, we will see lower motor neuron signs. And then we'll really want to see, is there any evidence of anything in the arms? The patient may be very focused on the gait, but depending on what their daily activities are, if gait is sort of the prominent thing and they're not doing a lot of manual tasks, then maybe there are arm symptoms that weren't noticed, or we see there are absent reflexes in the arms too. This is a more diffuse process than just sort of thoracic spine and below. So I guess we want the whole exam. Yeah, but we're probably most interested, if things go in the direction we presume they are, to figure out what's going on in the legs, strength, sensation, coordination, proprioception, and of course, to see what the gait actually looks like and if it fits into a pattern, though these can be very difficult to analyze. So what did you see, Doug, when you examined this patient?
Fantastic discussion so far, team. This is awesome to listen to. So on his exam, his mental status, cranial nerves were unremarkable. The motor exam, so he had normal bulk throughout, including in his tongue. He had spasticity in both legs, left greater than right. It was normal in the arms. There were no fasciculations noted with a pretty, a full body exam. He had no weakness noticed in the arms, even to subtle testing. His leg strength was notable for his iliopsoas were 4 out of 5 bilaterally. Quads were full strengths. He had a little bit of weakness in his left hamstring, about 4+. Gastrocs were normal. Tibialis anterior were normal bilaterally, and then his extensor hallucis longus was weak bilaterally, 4+ out of 5. He had, inversion and eversion were both full, as were hip adduction and abduction. In terms of his sensory exam, there was dullness to pinprick on both feet, the soles of both feet and all the toes. That was pretty symmetric. And then there was kind of patchy loss to sensation, to light touch and to pinprick, as well as to temperature, kind of going all the way up the leg. It was really quite patchy. Maybe a little bit more on the outer leg, the lateral leg, than the medial, but not a great pattern I can describe better than that. He had absent vibration at the toes and at the bilateral medial malleoli, and present vibration at the knees, and his joint position tense at the toes was also off. Coordination was normal for finger, nose, finger, and heel, knee, shin. His reflexes were 3+ in the biceps, brachioradiali. They were normal in the triceps. He had very brisk 3+ reflexes at the knees bilaterally, and he had absent ankle jerk reflexes. He had a left upgoing toe, and he had about 4 or 5 beats of clonus at his left ankle. Then his gait was, he could stand from seated, but he needed to push off with his arms. His knees would kind of be buckling completely until they were totally straight, at which time they would kind of stay locked. They would sort of, his toes were sort of inverted in toward the midline when he was walking, and his knees would sort of touch each other. He would sort of waddle back and forth with his legs very straight or buckling, and he could catch himself every time. And he took pretty slow steps. And then I didn't mention, but a Romberg sign that we tested was positive, but only after about 10 seconds. So not grossly positive, but he did start to sway and had to be caught after about 10 seconds.
Wow, a lot of information. Again, I think we've just sort of been going back and forth. So Promise, do you want to tell us what you think of this exam? And again, there's a lot here, so you can talk about it in aggregate or pull out 1 or 2 things that helped you think through the case here, or as you like.
I'm kind of overwhelmed.
Yeah, we all are. Yeah, Doug is good at that.
I felt like I'd been shortchanging you all in the exams recently. I wanted to give you a full exam, but
this is a beautiful full exam in all of its beautiful complexity. Yeah,
and feel free to take any piece of it.
That's exactly right. So I agree with Doug. Sometimes in real life, the exam is this overwhelming, and I often teach students that when they learn the neuro exam, they say, "Oh, it takes too long. I don't want to do it. It takes 20 minutes." And I say, "No, look, time me, and I can do the whole neuro exam, not mental status, presuming that patient's history was fine, cranial nerves all the way to the bottom in about 2.5 minutes, not because I'm speeding through it, just because I like to get a sense of the gestalt first. So in this patient, we would have run through and said, cranial nerves are fine, arms are largely fine, legs, okay, there's weakness here and all kinds of confusing pattern. There's sensation here that's definitely abnormal. There's abnormal reflexes, there's spasticity. Okay, but I've at least confirmed where I need to focus my exam. Now I'm gonna zoom in on the areas that are challenging. So I think we can do that in the discussion also, Promise. So if there is a part of this that you said, well, I know because X is Y, then Z, feel free. Or if, yeah, so I think that's what we would do in real life too. We'd say, well, let me just try to explain this one part of this and make sense of it.
Okay, I'll try my best. I'm trying really hard to think back to what I learned in neurophysical exam last year.
Yeah, so are all of us.
I thought that since the motor in terms of strength, it's actually higher than what I expected. I am going to try to focus more on the reflex and the sensory first. And I'm particularly concerned about that donus to pin prick, and then how there's like a patchy loss of sensation. I don't know if there's any differentials that has like a dermatomal loss versus like a patchy loss. So I'm like, that is something that I'm focusing on right now. And then let's see. I thought his gait exam is also something that I wanted to focus on.
What can you make of that pattern of gait? Does that, if you imagine what it would look like, does that pattern ring any bells?
I have not learned that yet.
No problem. Thank you for being honest. So you're about to learn it, which is great. So yeah, the sensory pattern. So thanks for picking off sort of one piece here. This is multimodal, right? There's pinprick, which we know travels in the small unmyelinated fibers in the nerves, and then through the spinal thalamic tract in the spinal cord up to the brain. And there's also vibration and proprioceptive loss, so our other pathway. And this is pretty symmetrical. So this actually tells us that there is sensory dysfunction here that's contributing, at least in some way, to the gait, since as you noticed, promise, he's not actually that weak. So the sensory component is definitely contributing somewhat here. And since it's symmetric and it's multimodal, we haven't really helped ourselves too much. It's still either in the spinal cord or the nerves, right? Great. Bill, what did you take away from this exam? And then I can comment on it also.
Yeah, I had similar thoughts with like the motor portion, that it was kind of not all that revealing. But then I was curious with the reflexes, especially. So if he's hyper reflexic up top, like the biceps and brachia, then it's like a cervical lesion. So if it was something, it has to be proximal to the lumbar. So it's kind of like two different symptoms. So he had like absent ankle reflexes, but he has peripheral neuropathy that's like bilateral. So it kind of confounds the exam, but not really, because we know that those absent ankle reflexes are, they're just going to be absent even if there was an upper motor neuron lesion. But he's also brisk at the knees. So it still kind of gives the upper motor neuron sign. And then he had clonus as well. So all of these things are contributing. And since there's the upper motor neuron sign, even like at the cervical region, which would go to like biceps brachia, curious if it's like something diffuse affecting the spinal cord. I'm really not sure though, but seeing that he had a normal heel shin, I'm not sure on like the sensitivity of the exam, knowing that like if heel shin is normal, can we roll out the cerebellum? I'm not too sure like how much of that we could do. I just don't know like what the actual sensitivity is, but.
No, I'm not sure anyone knows the actual sensitivity of that. Great, well, great discussion, right? So the sensory didn't tell us too much more, right? We were still either in the nerves or in the spine. But as you said, Bill, we have a lot of upper motor neuron signs here, and you listed them out for us. There's hyperreflexia, there's spasticity, there's clonus, there's a Babinski sign. So now we know at least part of this process is in the central nervous system. But as you said, well, wait a second, what about those missing ankle jerks? So as you said, one possibility is, well, take those Venn diagram circles apart, and we have a myelopathy, which is a spinal cord problem, and we have a neuropathy as two separate problems. And in most common settings, most common epidemiologic things you would see epidemiologically would be someone has cervical stenosis from degenerative disease of the spine and has peripheral neuropathy from diabetes, two processes, two superimposed sets of exam findings you would see as a result of that. But there are certain conditions that can cause a myeloneuropathy, meaning one condition causing spinal cord and peripheral nerve together. One of those is B12 deficiency. So subacute combined degeneration, the combined is the posterolateral aspects of the spinal cord, corticospinal tracts plus dorsal columns. But some patients have just the spinal cord part, some people have just the neuropathy part, and some people have a myeloneuropathy. So they'll have maybe absent reflexes and upgoing toes, or absent knee jerks and present ankle jerks. So that's one thing that can cause a myeloneuropathy. Copper deficiency is another one, which can be caused by excessive zinc intake from denture creams, though I think there were lawsuits and whatnot, and denture creams don't have that much zinc in them anymore because of this happening. Back to B12, you might say, well, the patient is on B12, but they're also on a proton pump inhibitor and may not be absorbing it. So those are two. And then if we wanted to get it into really rare stuff, the combination of myelopathy and neuropathy can be caused by adrenomyeloneuropathy, which is an inherited X-linked condition related to adrenoleukodystrophy, where the patient gets a myelopathy and a neuropathy together. I've seen one patient with this who actually didn't have much neuropathy and did have one brain lesion. So yeah, we don't know if the neuropathy and the myelopathy are caused by one underlying process or two processes in this patient. Just a couple of other little things on the exam. You mentioned, Promise, that gait looked like a pattern, but what pattern of gait is it? And you said you haven't learned it yet, and I promised you we would learn it. Bill, do you recognize that pattern of gait? Fine if you don't, and are you shaking your head no? So what is this gait? Well, first let's look closely at that pattern of weakness. There's a little bit of iliopsoas weakness, so hip flexion. There's strong knee extension, quadriceps. There is weak hamstring, Doug said. There is normal plantar and dorsiflexion, but some weakness in toe extension. So if you think of a patient you've seen who had a stroke a long time ago, or that Netter drawing of a patient who had a stroke a long time ago, who on one side has their arm held in flexion, elbow flex, wrist flex, fingers flex, thumb flex, and the leg held in extension with the foot in plantar flexion and inversion, right? That's the upper motor neuron pattern of weakness, right? So this patient has weakness in the opposite muscles, right? They have in the opposite muscles from those that are stronger and thus sort of dominate the spasticity picture. So this patient has weakness in hamstring, in EHL, and in iliopsoas. So that's sort of an upper motor neuron pattern. And so when the legs are spastic, the patient has to circumduct the legs to kind of bring them around. And you've probably seen this in a patient with an MCA stroke, or it doesn't have to be MCA, but an MCA stroke would be a common pattern. And they sort of use that leg, since it's stiff and straight, to kind of swing it around. And if the patient has bilateral spasticity, I can't really, the Zoom window is not big enough to try to show it with my hands here, and I would have to do a lot of moving around my computer to demonstrate it walking. Then you have both legs like that, you get what's sort of called a scissoring gait, where the patient is trying to walk with very stiff legs. And that is an upper motor neuron pattern that you see with bilateral spasticity, either from a spinal problem, or you can see that in children in cerebral palsy. So this patient has one lower motor neuron sign that we'll have to decide how that links in, or if that's just older stuff, and has a myelopathy, right, as Bill told us. How high up it goes? Well, there is upper extremity hyperreflexia, even though there's no weakness or spasticity in the arms. So this may be a diffuse spinal cord process, but since stuff has to go the longest way to get to the legs, we're thinking of something more that could be diffuse in the spinal cord, but affecting the legs predominantly, but with some hint of stuff in the arms. So with that in mind, we have to think about the differential diagnosis of disorders of the spine. And now that we've localized, we can add the second aspect of our equation, right? Localization and time course. So we have years of this going on. So this is a chronic myelopathy. So what, Bill and Promise, what would you sort of put on your differential here for a chronic myelopathy? And that'll help guide our diagnostic tests.
So I know I saw syphilis run across the chat. So it could be something infectious that has this like slow and kind of growing time course. I can't think of any other viral infections that are infectious, but then like the vasculitides, or actually spinal cord. I'm not sure.
Yeah. Right. So some infections, right? So syphilis is an example of an infection that can cause early meningitis or meningovascular syphilis, or late syphilis can cause tabes dorsalis, which is a disease of the spinal cord. I haven't seen cases of that. Maybe Doug has and can enlighten us. I don't think you should see this spasticity and weakness. It's really dorsal columns and dorsal roots. So the rest would sort of fit, but this spastic piece would probably take that off the table. So chronic infections, if Valeria was presenting, we would all be wondering about tuberculosis, right? Since she's presented several TB or not TB cases, right? HTLV1 myelopathy, also called tropical spastic paraparesis, could be considered. I think she's also presented us a case of that, I'm now remembering. And those patients can also have superimposed neuropathy. I have one very memorable patient who had myelopathy and HTLV1 associated motor neuron disease, if you can imagine that. So those are possible depending on the patient's prior exposures. Anything else you'd put on the list for chronic myelopathy, Promise? And then I can add a few.
Sorry, I don't have anything to add. I'm just learning about these.
No worries. Perfect. Thank you for your honesty. And so let's learn about them together. So B12 deficiency, which we've invoked, can cause this mix of upper and lower motor neuron signs. In principle, at least in a classic case, you shouldn't get pinprick loss, although maybe this patient has multiple processes. And in my experience, I've seen a lot of B12 deficiency in my work in Haiti. And the patients are usually, they can't walk, but they're not usually weak on objective motor testing in my experience. The gait dysfunction is from severe proprioceptive loss. So the lack of the Romberg here, or it taking so long to get a Romberg, to me would be a little inconsistent with that. And it's usually a little bit more subacute and not this chronic. So I probably wouldn't put it there. Benign neoplasms, that could be there for a long time, like neurofibroma, meningioma. We could think about in the vascular category, the commonly misdiagnosed, although not actually that common, dural AV fistula. This person is the right sort of age group for that, but usually those patients fluctuate a lot more rather than the sort of very chronic decline. Oh, that's something always to consider. And then there are hereditary myelopathies, and the patient, their parents may have passed away before they were a parent, or the patient may have a de novo mutation. So adrenomyeloneuropathy would be one, and they don't all have obvious adrenal dysfunction. And then hereditary spastic paraplegia, there's now, like the spinocerebellar ataxia, there's a growing list of HSP, and there's sort of classic HSP, hereditary spastic paraplegia, that just has spastic paraplegia. But there are, I think they're called complicated, or I forget what the terminology is, other HSPs that have other things. And I don't know, to be honest, since I haven't read in depth about these, aside from knowing that the entity exists, whether some can also have a lot of sensory dysfunction, rather than just affecting the long motor pathways, or whether that sensory dysfunction is from a superimposed cryoglobulin associated mononeuritis multiplex. So we definitely are going to have to take a picture of the spine, probably send some infectious serologies as a first pass. And then if we, and so that would probably be our first pass. And if we're really not sorted there, or the spine looks fine, we may also want to see if we get any clues from neurophysiology studies of the actual nerves, to see if that gives us any clues into what type of neuropathy we're dealing with. But I'm not sure how helpful that will be in this case, or at least as far as sort of whether we dissociate or lump the neuropathy and the myelopathy, the question Bill asked. So I suspect we got some cervical and thoracic spine imaging and a bunch of labs. And what did you and your colleagues find, Doug?
Great. Well, I can actually give you 2 time points, believe it or not. So this patient had been seen in a neurology clinic about 4 years earlier with the question of peripheral neuropathy, and had unfortunately been lost to follow-up after that. But the documented exam at that time also had hyperreflexia, had some patchy sensory loss, and a less impaired gait, but kind of the same nature. Excuse me. He did have at that time point, so 4 years before this, had a C-spine and T-spine MRI. Oh, did I freeze? Can you still hear me? Okay. C-spine and T-spine MRI without contrast that was unremarkable 4 years ago. So fast forward to our current visit, we got an MRI of the total spine and brain, intended to be with contrast, but for logistical reasons that didn't happen. So he got another one without contrast, and it was unremarkable.
Got it. Let's just pause there 1 second, Doug. Thank you. As you were talking, I forgot to mention in chronic myelopathy, we're thinking of all these morning report diagnoses. This is not the diagnoses. I'm not playing catch up now, but just to say the most common mundane thing you would see most commonly would just be spondylotic myelopathy. So it's my morning report hat on, and it's Doug presenting. So I'm thinking of all the exotic causes, but the most common thing would be degenerative wear and tear arthritis of the spine, which can either cause radiculopathy by pressing on the nerve roots, or if it's central, it can cause a myelopathy. And this would actually be a pretty good story for that, although we'd probably like to see a little more going on in the upper extremities. Right, Kirtan is reminding us, I just saw it fly through in the chat, that he gave us a morning report case that was a cervical myelopathy from degenerative disease. Obviously, all of those are off the table now because the imaging is normal. Did you want us to discuss briefly, Doug, or did you want to give us some more data up to, but not including the revealing data? And we'll...
I want to give you a little bit more data just up to the revealing data. And so just like you said, at the time point when I was seeing him, I knew he'd had symptoms and had structural imaging at that time. So we sort of taken him out of the compressive myelopathy category. We were also curious about a myeloneuropathy. He had an EMG nerve conduction study that showed a pretty mild length-dependent sensory motor axonal neuropathy that would not explain his findings. We did an extensive workup with a lot of the things that you all mentioned, his HIV and RPR, his copper, zinc were negative, B12 was normal, he was on supplementation already, folate was also normal. And we did an LP that had a normal opening pressure. It had a pleocytosis of 16 white cells that were 100% lymphocytic, a normal protein and a normal glucose, an elevated IgG index, and oligoclonal bands. Yeah, I'll stop there. And the next aliquot will reveal the diagnosis.
All right. Wow. So I think we were all wondering if we were going to see something in the spine. And as Doug said, we're thinking when we hear about the spine, is this compressive or non-compressive? For tumors, you would think of, is it extradural, intradural, extramedullary, or intramedullary? And I think that's a helpful framework in general for spinal lesions, but we got our scans and there's nothing, right? There's no structural lesion here. So we have to explain something that's causing a clinical myelopathy and neuropathy, but is not showing us anything on the imaging. So what would you think of, Promise and Bill, for an imaging negative myelopathy? And we have the LP data here to help us maybe a little bit as well.
So imaging negative just tells me that it's likely not something structural. So there still could be, I mean, you could see demyelination if it was significant or like over multiple levels. You definitely see that, but depending on the extent of the damage that was done, like it may not be able to be picked up on MRI and without contrast, especially. That's what I'm thinking about the imaging.
Yeah, so a lot of the things we could have thought of, right? One condition we didn't mention because this condition didn't seem to behave like it would be a demyelinating condition like multiple sclerosis or neuromyelitis optica. There is a primary progressive variant of multiple sclerosis that can predominantly affect the cord and could, I guess, have this similar story. It's very uncommon. Most patients are either relapsing remitting or relapsing remitting evolving to secondary progressive, but we would see evidence of that with lesions, as you said, Bill, in the cord. So I think that category is off the list. So yeah, lots of things are off the list. What could we keep on? Promise, any thoughts here?
I wish I wish I've learned all this right now, but I think looking at the lumbar puncture, the only thing I could say is the normal glucose and the protein tells me it's not an infection. And I look at the elevated IgG. I don't know what the oligoclonal bands means, but I feel like it's more of an inflammation problem.
Yeah, excellent, right? So, right, if you saw a very low glucose, you would think of particular infections, particularly bacterial, fungal, tubercular, although malignancies and sarcoid can also lower the glucose. So you see these white cells here and a lymphocytic predominance. And that tells us there's probably some inflammation. Now, if you see Promise or Bill, oligoclonal bands on the step or on your shelf exam, that's almost always going to be multiple sclerosis. But in real life, Doug and I learned as residents, and many of you have learned as well, that's just a non-specific marker that there is IgG production in the CSF space that can be inflammatory or infectious. And it doesn't, people sometimes think oligoclonal bands equals multiple sclerosis. That's not the case. And we have obviously no evidence whatsoever here of multiple sclerosis. So we have some type of inflammatory process here. And as you pointed out, but we haven't gotten a scan with contrast to see, is there a meningeal process here or something lighting up in the cord? So we're not sure. And so what is the last test Doug has withheld from us? We've taken HIV off the table, and HIV myelopathy and HIV myelopathy and neuropathy can occur. Neuropathy is pretty common. Myelopathy is usually only seen in patients with very advanced AIDS and probably also with superimposed dementia, opportunistic infection. So I think that's probably not right. So what could be an imaging negative myelopathy? Well, if you haven't showed me that LP, I'd be back to wondering about some of these genetic conditions. And I'm not sure if some of them can spill a little inflammation into the cord, but I wouldn't think so. So what could give us a chronic inflammatory myelopathy? I am not sure. HTLV1, although why would this patient have been exposed to that? Maybe we'll find out where he served in the Marines. And then if Doug is really out to stump us again, can hepatitis C very rarely cause some type of chronic smoldering myelitis? I haven't heard of that, but I'd be willing I'd be happy to learn about it. So I don't know what the final diagnosis here. I would say it's an inflammatory myelopathy. And what else would I send here? I guess I would send HTLV1. I guess I would want to do imaging with contrast, although I wouldn't hang my hat on making a final diagnosis there to see if there's sarcoidosis or some other process there. And I think the neuropathy is probably something separate, though we don't have a clear answer for what it is. So maybe they're all, I don't know. Valeria has written final diagnosis there to remind me that I have to go to my meeting at 10 o'clock and stop talking and get the diagnosis. All right, Doug, what did you, being much more clever than me, figure out to send here and make a final diagnosis?
Well, amazing job, you all. So his HTLV antibody came back positive in the CSF. I'm going to be honest with you that the way that it is reported at the VA as an outside study does not specify 1 or 2, which bothers me. I had never seen a case of HTLV associated myelopathy myelitis, so I got in touch with a wonderful neuroinfectious disease neurologist at UCSF, Felicia Chow, whose article on neurosyphilis you should all check out in this month's continuum from the AAN. It's fantastic, and I know Aaron knows that article well. So Felicia gave me an amazing schooling on HTLV, for which IV drug use is a major risk factor, as well as the geographic exposures and endemic areas, largely in Japan, Southeast Asia, and the Philippines. There's a longer list. Some of the places which he'd actually been in the Marines. He'd spent some time in China and in Japan. And I'll just give a quick, if it's okay, I can just, there's a great piece of the TX to this case. I talked to Dr. Chow, and she said, there are no evidence-based definitive treatments for HDLV. Unfortunately, a lot of things have been tried, things like interferon alpha, different anti-inflammatories, chemotherapeutics, steroids have been tried on a long-term basis. The things that are commonly done now are we will try steroids, usually high-dose pulse IV steroids. And then consider actually maintenance therapy on a medicine called raltegravir, which is a CCR4 inhibitor. So we had him admitted to the hospital. He had 3 days of pulse IV methylprednisolone. And after the first treatment, he got up and started crying tears of joy, because within like 8 to 12 hours, he felt like he could walk, and it was the first time he hadn't had pain in years. And then the subsequent treatments actually worked even better. And he walked out of the hospital feeling really quite well. Dr. Chow told me that anecdotally, in her experience, about 50% of people with HTLV have some response to IV steroids. And for those folks, she'll continue an IV infusion every other month or so until the response stops, and doesn't usually put people on maintenance steroids or chronic, oral prednisone. And we're starting him on IV oral raltegravir, with the help of some ID consultants, because he has this untreated hepatitis C that is also going to need to be treated, because he'll be kind of mildly immune suppressed on this medication. But the Dr. Chow's experience with raltegravir is that it seems to stabilize the disease if it has any effect at all. It can kind of help curb progression, although there are not randomized control trials around this, unsurprisingly. So I look forward to seeing him in clinic again. And if I get the chance, I'll report back to you all to see how his sustained response has been. Please
do. Thank you for that amazing case, Doug, and thanks for the follow-up. I've only seen very few patients with this. Valeria has seen many and has presented them before. I've seen people try steroids, and I've seen people try antiretroviral HIV treatment. Basically, I have not seen a dramatic response like this. So that's interesting, and you saw in the CSF, right, that there's some ongoing inflammatory process. So that's very interesting. I think we were so hesitant at the end, and then once we said that, we said, "Oh yeah, we've been talking about this the whole time." But it is funny to think what else would cause a chronic inflammatory imaging negative myelopathy. The list is relatively small, right? I think we were just wondering if this would be one of those tricky cases where, well, there's a few cells, but what do you do with that? But probably we could have hung our hat a little more on the oligoclonal bands telling us, yes, there is truly an inflammatory process here going on over years in the spinal cord. And then our differential gets pretty small, actually. So we made it there, but with less confidence maybe than we could have, at least in retrospect, once we framed the problem representation that way. Well, I'm going to have to unfortunately depart for is this still being recorded? Far less interesting meeting, but we'll edit that part out if we use this as a podcast. And we'll leave it to Valeria for teaching points. I'll have to duck out, but wonderful job, Promise and Bill, discussing a very complicated case and picking away at parts of it to get us to spinal cord and to get us to chronic, which was the key to this case, and to separate out what's neuropathy, what's myelopathy, what's foreground, what's background, what's causing the gait difficulty, and what are some things we could, as you know, happily talk about for hours more, but I will leave you in the capable hands of Valeria to give some teaching points, and look forward to more cases next Tuesday. Thanks, everyone.
Hi, Aaron. So yeah, quickly I'm gonna do the teaching points. It was an amazing case. Thank you so much, Doc, for the case. So we started with gait disturbance as a chief concern. And Bill introduced us to a lot of possibilities that could explain this gait disturbance, starting because of something affecting the strength, like weakness, or something affecting proprioception, coordination, vertigo, lightheadedness, or if this was ataxia. And I wanted to share this quote that I read from Mass General case from last month, that it was a balance, gait, and posture dependent 3 types of sensory outputs: proprioceptive, vestibular, and visual inputs. The integrator of these inputs is the cerebellum. So kind of, but it was more in the context of ataxia. But anyway, so then we were exploring the past medical history of the patient of peripheral neuropathy, and we could have mononeuropathy, but in this case was less likely, and the other 2 categories were more likely, or of mononeuropathy multiplex, which we can have inflammatory causes and then infectious causes, and with the past medical history of hepatitis C of the patient, it could be a possibility. Other infectious etiologies include leprosy, HIV, and Lyme, and then malignancy and diabetes that can also cause polyneuropathy, in which we should differentiate because of the tempo of disease. We can have acute onset polyneuropathy, but also chronic, in which case we include B12, B1 deficiency, diabetes, also because of chronic alcohol use, uremia, heavy metal intoxication, paraneoplastic presentations, inflammatory causes, and infectious etiologies such as HIV. And then we were thinking about the mix of upper motor neuron and lower motor neuron signs in this patient, and we could be thinking about a double presentation of disease, such as a Hickham's dictum type of picture, or an Occam's razor, in which Aaron introduced us to the myeloneuropathy possibility that could be consequence of B12 deficiency, copper deficiency, or an hereditary etiology as that is adrenomyeloneuropathy, and then HIV, which can also cause it. And then he also mentioned the upper motor neuron gait, which usually can be, for example, patients that have a past stroke, and what we will have is an extensor weakness in the upper extremities versus a flexor weakness in the lower extremities. And so the patient will present with arm, wrist, and fingers flexed and pronated to the body, whereas the knees are, or the knee affected is extended, and there's going to be plantarflexion and circumduction when walking. And then using the tempo of disease, we kind of made a differential of chronic myelopathy, in which the most common cause is spondylotic myelopathy, and then infectious etiologies such as TB, HLV1, which was the final diagnosis, and then other etiologies such as B12 deficiency, benign neoplasms, viral etiologies, and hereditary causes as well. And well, then the final pearl that Aaron and Doc mentioned was the fact that oligoclonal bands are not a synonym of multiple sclerosis, but just indicate inflammatory or IgG presence on the CSF. So thank you so much for the discussion on the case. It was great, and hope to see you all tomorrow.
Great job, everybody. Great to see you all.